Welcome to a Longwoods Leadership Discussion. Today, we are here to discuss the guidelines for and management for COPD. All of you who are here today have some sort of involvement in the management of COPD, whether or not that be through clinical or administration. But most of us will also experience this through our personal lives, either as a patient or a caregiver. The more resources and tools that we have and the understanding of how these tools can support us, we're all the better for it. Today, we are joined by a number of leaders and drivers in the management of COPD. I will put some links up to the speakers in the chat for you to review. To lead us through today's discussion is I would like to welcome the Director of Asthma and COPD Clinics for the University of Alberta, Dr. Mohit Bhutani. Mohit, it is all yours.
Thanks, Matthew. Good morning, everybody, or good afternoon, depending on where you are in the country. I'm just going to start sharing my screen here. Give me 2 seconds. Ready. So thanks for joining us today on this webinar on the Canadian Thoracic Society COPD Pharmacotherapy Guidelines. It really is implementing science to improve patient outcomes. I have the privilege to be joined with my colleagues from across Canada. I've got Dr. Jean Bourbeau from McGill University in Montreal. I've got Dr. Paul Hernandez from Dalhousie University in Halifax, and Dr. Brandie Walker from the University of Calgary in Calgary. This is who I am, and those are my conflicts of interest. These are our learning objectives for today, which is to review the current state of COPD, importantly, to review the 2023 CTS COPD pharmacotherapy guidelines, and ultimately discuss case studies and really give you some sense of how we think these guidelines should be implemented in clinical care. But at the end of the day, our main objective is to making a case for proactive COPD treatment and making that proactive case for treatment now. Our patients with COPD and our health systems are dealing with a significant burden, and this proactive management is really being demanded of us at this stage. The COPD is the third leading cause of death worldwide, and its prevalence is increasing across the globe, and including in Canada. The current state that we have with COPD is something that should not be a surprise to any of us. In 2005, the Canadian Thoracic Society and the Lung Association did a national audit of COPD care across the country and published this national report card. So this is 2005. There's a lot of key messages, but what I want to highlight to you is a couple of them. One was in 2005, the majority of provinces received a grade D or lower for the metrics that they used for COPD management. And in fact, 3 provinces are actually failing. They highlighted the fact that provinces are not fully complying with the Canadian Thoracic Society COPD guidelines regarding medications. And at the end of the day, their bottom line was that COPD needed to be put onto national and provincial health agendas to improve outcomes. Now, in 2005 onwards, lots of great work led by my colleagues on the panel here today have helped prioritize COPD and have helped improve our understanding of how to better take care of our patients. But unfortunately, when it relates to hospitalizations, we really haven't had a tremendous impact. This publication that was published last year in the Canadian Medical Association Journal, called Trends in Hospital Admissions for Chronic Obstructive Pulmonary Disease over a 16-year period, really gave us a good insight as to how things were going. And they weren't going really well. In the top line, you see all-cause hospitalizations from 2002 to 2016, and you're seeing a nice line, a nice trend downwards for all-cause hospitalizations. But when you see COPD hospitalizations over that same time period, you're seeing a bit of a roller coaster, and you start seeing an up and down trend. But on average, you could sort of say that things are either trending up in terms of hospitalizations or have remained the same over that same 16-year time span. So, although we've got all this knowledge, we haven't been able to affect hospitalizations, and hospitalizations are, the biggest cost that we spend on COPD care in general. What's come through all of this is that COPD exacerbations or lung attacks or flare-ups are the #1 cause for hospitalizations in the country and have remained so for the last 10 to 15 years with very long lengths of stay. And that contributes to poor outcomes for our patients and a lot of expense for our health system. And this needs to change, and this needs to change now. Some of the things that we've realized when it comes to COPD care is that COPD is a disease, but it's associated with a lot of comorbidities. And when patients have these hospitalizations, it actually destabilizes other chronic conditions, in particular like cardiovascular disease. And this study called ExaxoCV looked at 4 databases in Canada, Germany, Spain, and the Netherlands. And it looked at patients who were hospitalized for a COPD exacerbation or lung attack and looked at the week after, the days after, the month after, the months after, and the year after having a hospitalization. And what did it do to patients who had comorbid heart disease? As you can see, everything sits to the right of these dashed lines, suggesting that patients have more decompensated heart failure, are more likely to have heart attacks, are more likely to have strokes, and more likely to have arrhythmias following these exacerbations. So a COPD exacerbation is not only impactful to the lungs, but it also has a fairly significant impact on comorbid conditions, including cardiovascular disease. So at the end of the day, one of the challenges that we have to provide good care is formulary access. Across Canada, many formularies are not in alignment with the recommendations and have not, and this has been the case since 2005. There's significant variance between provinces. A patient in British Columbia does not have access to the same medications as a patient in Atlantic Canada. And this results in patients not always being able to get the right medication for their clinical needs. And that results in poor outcomes and increased healthcare utilization and costs. So the change is needed and needed now. And we do feel that our guidelines, the new guidelines we have, will help address this. And we want to share this with you today. So with that, I'm going to pass it on to my colleague, Dr. Bourbeau, to lead you through the early discussions. John?
Thank you very much, Mohit. That's quite an impactful introduction. If after that we are not prepared to take action, and action mean that it's about questioning what we've been doing, and also questioning how we can work not only at the patient level, but at the provincial level, hospital level. And I think all these actions have to be taken, and they're not going to come from above, but they're going to come from us. And these are my conflict of interest. I'm also a member of the scientific committee of GOAL. We hopefully we can answer some question at the end related to this. Then the guideline objective was really to help clinician match pharmacological. This is a guideline on pharmacological treatment. This is an important step toward personalized therapy based on an individual characterization, to provide a clinical guidance with evidence-based. That's important that you realize evidence-based recommendation from a systematic review with the meta-analysis and expert-informed clinical remark to optimize maintenance pharmacology, in fact, aiming at alleviating dyspnea, improving health status, then preventing exacerbation, and for the first time, a guideline aiming at reducing mortality for individuals with stable COPD. Then what this guideline is not, and sometimes it's more important to know what this is not. This guideline will not address the non-pharmacology, although the first figure is highlighting the comprehensive and integrated approach in terms of evaluation and in terms of pharmacology and non-pharmacology. And this is essentially to remind people that even this is a guideline on pharmacology treatment, the approach that we should have for these patients is pharmacology and non-pharmacology. And it's not addressing biomarker blood eosinophil count because they rely essentially on the RCT, and there hasn't been any RCT up front that had the enrolled patient based on the characteristic of blood eosinophil. And all the information we have on blood eosinophil are coming from post-hoc analysis or coming from analysis on retrospective study. In terms of the definition, it's important when we're going to talk here about stable COPD, what are we referring to? Essentially, all clinical state other than during the period of an acute exacerbation. That's what we mean by stable. We don't mean that the patient could not be improved in terms of the treatment. Acute exacerbation here is really event-based occurrence, and we are defining based on the respiratory symptoms that worsen beyond the normal day-to-day. And the severity is the operational definition that have been used in most of the study still, and this is why we reflect on that, because the evidence are based on these definitions: mild being worsening of new respiratory symptoms without a change in prescribed medication, moderate is prescribed antibiotic and or oral corticosteroid, and severe requiring an hospital admission or emergency department visit. When we're going to talk in this guideline about low and high risk of future exacerbation, individuals are considered to be low risk if they had one or less moderate exacerbation in the last year and did not require an emergency department visit or hospitalization, where the high risk is either 2 moderate or more, or 1 severe exacerbation in the last year requiring hospital admission or emergency department visit. Then this is when the study have been done using these definitions, and this is what is going to allow us to be evidence-based using similar definition when we generalize to our practice. If we can rely on the evidence, we have first to know that is this methodology used in the Canadian Thoracic Guideline is reliable. And this guideline is following the highest standard in terms of, first of all, quantitative evaluation using meta-analysis of each outcome. Only RCT have been considered in this guideline. The outcome have been divided into 3 PICO. PICO 1 being focused on the outcome of dyspnea, health status, exercise tolerance, physical activity. PICO 2 on exacerbation. And for the first time, and the only guideline to our knowledge still, PICO 3 on mortality. Although GOLD addressed the issue of mortality, GOLD is not a guideline. Grade system has been used in terms of study design, risk of bias, and consistency, and directness, and precision, and other consideration. The Grade Pro guideline developed tool was used to assess the certainty of the evidence for each PICO question outcome that we can rate as high, moderate, low, or very low. The strength of each recommendation was established has been strong or weak, and the evidence are presented in a summary finding table that you have in the forest plot that you can find in the supplement of the article. The quality of the evidence is indicated in the recommendation that you can find in the table of the main manuscript. And this has been reviewed to the entire guideline, the panel. When there were lack of data, the panel indicated and employ expert consensus opinion. This is from the Prisma diagram where we end up with over 200 studies that were included in the quantitative evaluation from the surge here from 2019 guideline up to 2022 for PICO 1 and 2. And PICO 3 had a similar surge that was conducted because PICO 3 was for the first time, as opposed to PICO 1 and 2 that was an updated from 2019. Finally, the guideline review process included CTS independently invited formal reviewer by 5 external non-CTS content expert coming from 5 different countries and 2 internal CTS member. This was also aligned by a peer review process in our Canadian journal and in CHESS, where the 2 were done separately. And you have over 200 pages in the 3 appendices in addition to the manuscript, where you can see the risk of bias, meta-analysis, forest plots, funnel plot as well, and other information on the methodology that goes in much detail. The way that the recommendations are presented, this is an example from the main manuscript, where you have the clearly this is PICO 1, and you have the question at the top. Then you have the specific comparison and recommendation here. For example, here it's stable COPD at low risk of exacerbation with low symptoms burden and health status, and what it means in terms of measure by what. Only mild impaired lung function. We recommended starting initial monotherapy with either LAMA or LABA. And then you have the strength of the recommendation. You have the certainty of the evidence, depending of which recommendation based on which outcome, okay, and compared to what. That's why you have 3 here. I compare LABA, LAMA compared to placebo, LAMA monotherapy compared to LABA, and LAMA or LAMA compared to placebo. And then you have also in reference to what you should refer in the supplement with the evidence from the meta-analysis. Then it is very, very detailed. Let's move on now into the recommendation. Paul, please, you are taking over from here.
Thank you, Jean, and hello, everyone. It's a pleasure to be part of this panel. These are my conflicts of interest. And as Jean has nicely outlined, my job is in the next few minutes to distill those 280 pages of evidence into a few slides. I'll start with, well, just to make sure that we're all on the same page, recognition that as Mohit has indicated at the outset, COPD is an extremely important condition in Canada in terms of its epidemiology, and it's extremely important in terms of how it affects the lives who live with COPD. Patients with COPD often live with high symptom burden, are at risk of exacerbations, and of increased mortality. And COPD is not just one disease, it's quite a heterogeneous condition. And it differs from one patient to the next. Despite that, when we are suspecting clinically that a patient might have COPD, we do need to confirm that clinical suspicion with spirometry to demonstrate that, in fact, the patient does have evidence of airflow obstruction and that it doesn't fully reverse with bronchodilators. We can also use spirometry to assess the extent and severity of airflow obstruction. But we also need to do a more comprehensive and thorough clinical evaluation of our patients with COPD to identify potentially treatable traits, targets for our treatment, so to assess their symptom burden and to assess, as Jean has indicated, their risk of exacerbations. So spirometry is essential to confirm the diagnosis of COPD, and that we need to demonstrate airflow obstruction, that is the forced expired volume or in 1 second, or FEV1, over the forced vital capacity, FVC, a reduction in that ratio, typically below 0.7 or the lower limit of normal. And then we can also use spirometry in comparison to the percent predicted for that individual to determine the severity of lung function impairment. And this CTS has adopted the GOLD classification of impairment of lung function. GOLD 1 or mild are patients with FEV1s above 80%. GOLD 2, moderate, 50 to 80%. 3, severe, 30 to 50. And GOLD 4, very severe with FEV1s below 30% predicted. A more comprehensive assessment of the impact of airflow obstruction in a patient requires an assessment of symptoms severity. And for this, we can look at the most important symptom that patients experience when living with COPD, that is dyspnea and exercise intolerance associated with that disability. And we can use a simple scale like the modified MRC dyspnea scale from grade 0 to 4 to classify disease severity as mild, grade 1, moderate, grade 2 or 3, or severe, grade 4. Patients with COPD have symptoms in addition to shortness of breath, other symptoms, and we might be able to quantify those clinically in our patients using a simple tool such as the COPD assessment test. And this is a simple 8-item questionnaire that patients can self-administer. And for each of the 8 questions that look at different aspects in terms of symptom burden of living with COPD, They can grade the symptom from 0 to 5, add up the answers to each of those questions, and get a total score. And we define patients as having a low impact or low symptom burden from their COPD as a score below 10, and those with a high symptom burden as 10 or more. And we use these definitions in our pharmacotherapy recommendations that you'll see shortly. So let's come to the PICO questions that Jean mentioned earlier, and the recommendations that we have with respect to pharmacotherapy for these for patients with COPD. So PICO 1 is how does a clinician choose appropriate maintenance pharmacotherapy in individuals with COPD to reduce symptom burden and improve their health status, or some call it health-related quality of life. So if we're starting with individuals who have a low symptom burden, well-preserved health status, and mild airflow obstruction, that is MMRC of 1, CAT less than 10, and FEV1 greater than or equal to 80% predicted, we would recommend that those individuals be started on a long-acting bronchodilator, either a LAMA or a LABA monotherapy. And this represents a change from our 2019 guidelines. In those patients at that time, we recommended just using a short-acting bronchodilator, but there is a substantial evidence that would suggest that a right approach from an evidence-based recommendation is to start with a long-acting beta bronchodilator. And this is demonstrated, as Jean indicated, in meta-analysis and from our systematic review. And here you can see the forest plots showing LAMAs compared to placebo with respect to changes in dyspnea, the TDI, in respect to health status using the St. George's Respiratory Questionnaire, the SGRQ, and in terms of lung function. And in all of those outcomes, you can see that the long-acting bronchodilator is favored over placebo, recognizing that placebo in these trials means that the patients have access to use of short-acting bronchodilators. And then similar to the LABAs also are favored over placebo in terms of improving those outcomes. If we move now to individuals who are more symptomatic, who have a higher symptom burden, and more negatively impaired health status, and perhaps worse lung function, but who remain at low risk of future exacerbations. In those individuals, we make a strong recommendation to use a combination or a dual long-acting bronchodilator with both a LAMA and a LABA. And again, this represents a change from our 2019 recommendations in which we recommended that patients be treated with monotherapy. And to support that recommendation, again, we have, I'm just showing some of the evidence here. We have the forest plots demonstrating, again, with respect to either dyspnea or quality of life or health status, that the use of dual long-acting bronchodilators is favored over the use of monotherapy. In that same patient population with moderate to high symptom burden, but low risk of exacerbations, if they remain symptomatic despite the use of a LAMA-LABA, then we would recommend stepping up to a triple LAMA-LABA-ICS combination therapy. And this is not a change from our previous recommendations. And the evidence for this, again, from the forest plots, comparing triple therapy to the LAMA-LABA dual therapy shows that this favors triple therapy in terms of improvements in dyspnea and quality of life. And similarly, it shows it versus ICS-LABA. Now, moving on, just an important difference in our guidelines this year compared to 2023 compared to 2019. We do not suggest that there's any role for stepping down of therapy. Once patients have been started on appropriate therapy for their COPD, based on an appropriate and comprehensive clinical assessment, there's no role for stepping back because that places patients at increased risk for worsening of their symptoms and the development of exacerbations. Let's move on to PICO 2. In PICO 2, we ask the question, how does a clinician choose appropriate maintenance pharmacotherapies in patients with stable COPD to reduce the risk of exacerbations? And Mohit has showed the extreme importance of exacerbations to the healthcare system. And we know that exacerbations have a major negative impact on patients as well in terms of lung function, quality of life, and increased risk of mortality. So in individuals at low risk of exacerbations, but who have a moderate to high symptom burden, we do recommend that they start on a dual LAMA-LABA maintenance therapy. And this is unchanged from 2019 and is in agreement with our recommendation in this patient group if we want to improve their symptoms and quality of life. However, if we move on to the patients with moderate to high symptom burden and health status impairment, who are at high risk of exacerbations, and Jean has indicated that these are individuals who have either frequent moderate or any severe exacerbations resulting in hospitalization, we would recommend strongly that those individuals be started on a triple therapy with a LAMA-LABA ICS. And this represents a significant change from 2019, in which case we had indicated that those patients be started on a dual or ICS-LABA combination therapy and step up only if they failed. So this is a significant change from our previous recommendations. But this is backed up by strong evidence from a number of studies that have been published since our 2019 guidelines, demonstrating the benefit of triple therapy compared to LAMA-LABA for exacerbation reduction, whether we're talking about moderate or severe exacerbations. And similarly, the benefits of triple therapy versus ICS-LABA for reducing exacerbations, whether moderate or severe. If patients in this group who are at high risk of exacerbations continue to exacerbate despite triple therapy, that's when we would recommend the addition of an oral therapy. And we have three broad classes of medications to use, either macrolides or PDE4 inhibitors or mucolytics. Finally, and importantly, this is a new PICO question that we've asked in the most recent guidelines. How does a clinician choose appropriate maintenance pharmacotherapies in patients with stable COPD to reduce mortality? And this is particularly important in that patient group, the high-risk group with high symptom burden, impaired lung function, who are at high risk of exacerbations, because we know that exacerbations carry a high risk of mortality. And we make a strong recommendation that to reduce mortality, patients should be on a LAMA-LABA ICS triple combination therapy. And again, this is supported by a number of RCTs, which have demonstrated the mortality risk reduction associated with triple therapy versus LAMA-LABA dual therapy. Now, that same mortality benefit has not been demonstrated versus ICS-LABA, but I would remind you that when comparing triple therapy to ICS-LABA in this high-risk patient group, you do reduce exacerbations, improve quality of life, and symptoms. And so for that, on that reason, there is enough reason to recommend triple therapy, not only to improve symptoms and reduce exacerbations, but also to improve mortality in that high-risk group. So finishing up, before I pass it on to Brandie to show how you would implement these recommendations in practice, two figures. The figure one here that I'm showing you, as Jean indicated at the outset, puts it all together in terms of how we would integrate comprehensive management of our patients with COPD. At the bottom left corner, you can see that diagnosis should be confirmed with spirometry. And then across the bottom, the orange bars, you can see how we should comprehensively assess our patients with COPD in terms of measurement of the degree of lung function impairment, disability related to shortness of breath, the impact on health status from their symptom burden with a tool like CAT, and assessing their risk for exacerbations, which also portends an increased risk for mortality. So we would see where that an individual fits across those orange bars across the bottom. And then we would draw a line up to see which of the therapies, both pharmacological and non-pharmacological, would be important to offer to our patient, recognizing the essential and critical part of not just pharmacotherapy, but also non-pharmacological therapies such as smoking cessation, self-management education, encouraging exercise and active lifestyle, and in patients with more moderate to severe disease, other therapies such as pulmonary rehabilitation. And then finally, the pharmacotherapy algorithm to put it all together based on our 3 PICO questions. The first thing you would do in assessing a patient in terms of which pharmacotherapy is right for them, you would say, what is their degree of symptom burden and quality of life impairment and lung function impairment? If the patient is mild, that is MMRC of 1, CAT less than 10, FEV1 well preserved, and they therefore have a low symptom burden, we would recommend treating those patients with a monotherapy with a long-acting bronchodilator, either a LAMA or a LABA. If, however, patients have more moderate to severe disease, that is an MMRC of 2 or greater, a CAT score of 10 or greater, FEV1 less than 80% predicted, the next thing we would do is assess their future risk of exacerbations, and that is largely based on their past history of recent exacerbations. Those patients at low future risk of exacerbations, but high symptom burden, we would start them on a dual long-acting bronchodilator, a LAMA-LABA, and if they remain persistently symptomatic, we would advance those patients on to triple therapy. Whereas those patients that worry all of us the most, those patients who have a high symptom burden and a history of either severe exacerbations or frequent moderate exacerbations in the past, therefore at high risk of future events and high risk of mortality, those individuals should be started right from the start on triple therapy with a LAMA-LABA ICS. And if those patients continue to exacerbate in spite of those therapies, they should be considered for the addition of oral therapies. And finally, all of these patients should have access to a short-acting bronchodilator for acute rescue relief, as indicated at the bottom of the slide. So that's a lot of evidence to share, but importantly, Brandie now is going to show you how you would implement that with some case illustrations. So I'll stop there and pass it on to Brandie.
Thanks, Paul. I'm just going to pull up my slides here. Let's see. And okay, so just my conflict of interest slide. So thank you. I'm tasked today with taking us through a couple of cases, fairly common sort of clinical scenarios that we might see to illustrate how to actually go ahead and apply our guidelines. So case number 1, we have John, and John is a 62-year-old male who's an ex-smoker, and we're seeing him in hospital. So we're consulting to his admitting service. He was admitted about 5 days ago with a severe acute exacerbation of COPD. When he first came in, he was very dyspneic, and he actually required 24 hours of bi-level ventilation or BiPAP because he was acutely hypercarbic, so in acute hypercapnic respiratory failure. He also received sort of the standard that we give for acute exacerbation in hospital, so treatment with prednisone, oral antibiotics, and short-acting bronchodilators. So treated appropriately for his presentation. In speaking with him, we determined that before he was admitted, when he was at his baseline, he actually was fairly symptomatic, so dyspneic, walking on the level for short distances, and he had appropriate diagnostic testing to determine that he has fairly severe COPD. So he had a reduced ratio, and his FEV1 was 24% of predicted prior to his admission. Before coming into hospital, he was treated with a long-acting muscarinic antagonist, so tiotropium, and he had the short-acting salbutamol. So the questions that we want to really think about as we're consulting for John here is, how are we going to optimize his pharmacotherapy upon discharge? And what other types of therapies might we consider in order to optimize his COPD management and ultimately reduce the risk of future hospitalizations for acute exacerbations here? So if we think about patients with acute exacerbation of COPD, we know that reducing reducing the risk of another exacerbation is very important, because each of these events has big impacts in terms of our individual patients. So reduced health-related quality of life. And this is both in terms of a prolonged recovery phase, and also the fact that many patients never get back to the level of quality of life that they enjoyed prior to their exacerbation. We have to think about the increased mortality that's associated with acute exacerbations of COPD. So as Mohit mentioned, a recent study in the International Journal of COPD in 2024 demonstrated an increased risk of death for up to 2 years after an acute exacerbation that results in a hospitalization. So huge impact to the individual. We also see accelerated decline in lung function. So over time, patients with COPD will experience decline in lung function, but this is an event that results in a rapid decline and often a sustained decline. So big impacts in terms of the individual again. And then if we think about the health resource utilization, or the system level impact of acute exacerbations, because of the number of patients that we see with this disease, it's not surprising that there's increased cost and health resource utilization with each of these events. This is just a study that demonstrates that we shouldn't just be thinking about pharmacotherapy here. In this study, a group of experts was consulted to see what sorts of interventions would they consider really important when a patient is being discharged from hospital. And so in this study, not only did they determine that optimized, reconciled prescriptions for the respiratory medications is essential, but you also have to ensure that the patient can use the medication. So with all of our inhaled medications, of course, it's paramount that the patient has adequate inhaler technique. They also identified that a discharge summary sent to the family physician would be ideal in order to make sure that any changes that are happening in hospital are communicated and follow-up arranged so that that patient can be checked in a very timely fashion. Also essential is a written discharge management plan for the patient. When big changes to medications or plans of care are made in hospital, they need to be communicated to the family physician, of course, but also to the patient and the caregivers so that everybody is following the plan. Finally, referral to pulmonary rehab we'll touch upon. Screening for frailty and comorbid conditions. And here I would put a real emphasis on any uncontrolled cardiac risk factors. So you need to optimize patients with respect to their cardiac risk. And this is a great opportunity to do that when patients are being discharged from hospital. And then, of course, assessing their smoking status and, if appropriate, counseling for smoking cessation. So here we're looking at that figure 1 that's already been introduced to us. And at the base there, you see our patient parameters. So John has definitely got very severe lung function impairment. He's quite symptomatic, and he's currently in hospital with an acute exacerbation. So we can agree that he would be at the very far end of this this diagram. And so what we do next is go vertically. And so everything vertical from the point that we've placed our patient, those are the things that would be appropriate at this point in time. So our fellow John should be getting self-management education. He's an ex-smoker, so we just would confirm that he has still ceased smoking. Counsel him with respect to exercise and active lifestyle, the vaccinations that are appropriate, and he's already on an inhaled short-acting bronchodilator. We're going to think about on the next slide which medication he should have, but definitely referral to pulmonary rehab would be important. We might consider other pharmacotherapies, and then, if appropriate, oxygen and non-invasive ventilation. And this is our figure 3 going through the pharmacotherapy that would be appropriate. So I think we can all agree that, again, John is going to be at the far side of this table. So he's definitely got severe lung function impairment and is symptomatic. He's currently in hospital with a severe acute exacerbation. So it would be appropriate to have him on triple inhaler therapy, so the LAMA, LABA, ICS, to help reduce his risk of mortality going forward. And the little asterisk there indicates that ideally we would like him to be on a single inhaler triple therapy. Just a couple of comments about inhaler device, and that is that choosing an inhaler is really an important choice, but it has to be made in combination with the patient so that they can use the device that you're prescribing for them. Preference comes into play. Insurance coverage definitely comes into play, because if a patient can't afford to purchase their medication when they leave hospital, then that is a huge barrier and a big risk for another exacerbation. Finally, if all things are equal, then environmental impact of the inhaler that you're choosing would be something important to consider as well. In the studies that we use to inform our guidelines, many of those studies are single inhaler triple therapies, so one inhaler device. That's an ideal. It's not always possible, but we do have really good evidence to demonstrate that if a patient has a whole bunch of different devices, all with different inhalation techniques, then that can increase the risk of exacerbations and just uncontrolled disease. I'm going to skip the blood eosinophil stuff in for time here. This is just a study that demonstrates that real gains can be made when patients really understand or have access to self-management education. So this is hospitalization risk, and a reduction is definitely seen when patients have the opportunity to have some self-management skills incorporated there. And this is a demonstration that particularly after an acute exacerbation event, hospital admissions can be reduced by having patients participate in pulmonary rehab. So this is an augmented step to that proper pharmacotherapy, which is, of course, also important. Just to point out that in severe COPD, like our patient here, we didn't talk about whether or not he would be appropriate for long-term oxygen, but if somebody is appropriate for long-term oxygen and remains hypercapnic, then there is a recommendation for long-term non-invasive ventilation therapy. However, in many parts of the country, this is hard to access. So very quickly to go through Deborah. Case number 2, 65-year-old former smoker. She has a diagnosis of COPD made objectively with spirometry, but it's moderate. So her FEV1 is 69% of predicted. She's on salbutamol inhaler up to 4 times daily, and she finds that she's still dyspneic. So she doesn't actually want to participate playing with her grandkids as much anymore because she's short of breath when she does that, and she's stopped golfing. No previous episodes of acute exacerbation. So if we're thinking about pharmacotherapy that would be appropriate for Deborah based on our guidelines, again, we're going to look at figure 1. And she's more in that moderate category. So her lung function impairment was moderate, and her dyspnea scores are moderate. So slightly different, although we are still going to give everybody that self-management education, exercise and active lifestyle recommendations, vaccinations. But again, she doesn't have that preventative therapy that's going to be really important. So on our figure 3, she's going to end up, again, she's in that moderate category, but she's not had an exacerbation of COPD. I point out that it's really important to ask some probing questions around that to make sure that we're convinced that she really hasn't had acute exacerbations. But if we're confident in our category here, then we would put her on a dual bronchodilator therapy, LAMA-LABA. Finally, just to point out that pulmonary rehab has a fair amount of evidence to show that it's important for optimizing our patients with COPD, and particularly in concert with being on the right medical therapy. So in this study, patients had a long-acting bronchodilator versus no long-acting bronchodilator and went through pulmonary rehab. And the endurance time improvement was significant, and it was maintained for quite a long time after treatment. So these combinations of therapies are really important when we're thinking about comprehensive care in our patients with acute exacerbation of COPD. And I'm going to stop sharing here, and we have some time left here for questions.
Well, fantastic job, everybody. That was excellent summary of the guidelines that have been, to say the least, a yeoman's amount of work to put together. There are some good questions that are coming through in the chat, and I'm going to maybe address Gary and Rebecca's question. And to be honest, folks, this is the reason why we're doing this, is because there is a disconnect between, the question is about the disconnect between the guidelines and what we can access, and what we wanted to do today was really to bring this issue to attention to payers that maybe, and policymakers that are on the webinar today and who may watch this later. But maybe I'll ask every one of you to comment, Brandie first, Paul, and then Jean, about how this disconnect affects your guys' practice and what you think needs to be done. So maybe Brandie first, then Jean.
Sure. Yeah, it's certainly an issue. So if we think back to the first case that I talked about, where our patient was in hospital, and prior to the hospitalization was on a long-acting muscarinic antagonist in Alberta, we would, if he was on Blue Cross formulary, we would not be able to send him out of the hospital on optimized therapy. So we're delaying optimized care by having being forced to do sort of a stepwise approach, which I think is a real barrier, and also doesn't allow for timely optimization, which we know potentially impacts long-term health in these individuals.
Paul, do you want to comment?
Yeah, we had a recent change in Nova Scotia, where I work, where respirologists are now allowed to prescribe any inhaled therapy without the need to fill out any forms, which is fantastic. But of course, we are only 12 respirologists in the province, and we didn't write the guidelines for respirologists. We wrote the guidelines for primary care physicians and internists, who look after the vast majority of patients with COPD. So it's great that I can follow the guidelines, as Brandie indicated, when I see a patient in hospital and I send them home on the right therapies. But what we really need is access without necessarily going through steps that we know are suboptimal. Why would I start a patient on a therapy which I know is inferior, wait for them to fail before I can prescribe them the therapy that they needed in the first place? We wouldn't do that approach in any other setting. And I'm probably going to steal Jean's comment, but we would not send home someone from the hospital with a heart attack. With aspirin, wait for them to come back, and then add a beta blocker, wait for them to come back, and then add a so on. So we don't do that failure stepwise approach for other chronic conditions. And we should not expect that our patients with COPD should have to go through that process. So great for me as a respirologist that I can follow the guidelines appropriately, but family physicians and others are still forced to do an approach which I would consider suboptimal for their patients, sadly.
Yeah. I let me just end this, Mohit, when I'm going to play the tough guy here. I'm going to be retiring a few years from now. I'm going to blame who should be blamed, and we should be the one, okay, that we should blame ourselves for not doing the job. We shouldn't expect the payer. We shouldn't expect anyone else, okay, to do what we should be doing. I'm not saying it's easy. Okay, but I become very creative, okay, when it is for the good of my patient, and I hate to wait when I know that we're not giving the best, okay, for our patient. Then I think we have to change our attitude. There are still people who are going to talk about this first patient that Brandie presented, okay, that this patient would end up to be on dual long acting in many places. You'll be surprised, okay? I could give you example of patient coming from Florida, patient from my own institution. It absolutely doesn't make sense. Then I invited everyone there to be very creative, okay? As long, okay, that you're doing it for the best of your patient, and obviously to fight to make sure, okay, that our patient should have the same quality of treatment than any other disease. And I will reinforce what Paul has said. I don't know any other disease where we would accept that. And we keep accepting that in COPD.
So it seems like this is a national problem, and maybe at the end we'll speak to what we're doing at the CTS regarding trying to address some of these disconnects. But the one thing that, John, you sit on the GOLD Scientific Committee, and you are an author of the GOLD recommendations. Do you maybe just want to highlight to the folks the differentiation between our guidelines and what GOLD is, and maybe talk about some of the nuances that are the differences between the two, because GOLD is often referred to, and we see this very, very prominently across the country. So, but let's differentiate them and explain why CTS is maybe a better way to go.
Yeah, Don Sin and myself, we wrote a common paper in CHESS regarding similarity and difference between GOLD and CTS, and I will start with the similarity. The two have a lot of similarity in terms of goal of treatment, in terms of treatable threat, dyspnea, burden, and exacerbation. Both are a systematic review. And if you look at the group that have mild symptoms, we're both recommending to use long-acting monotherapy. It is written in the text of GOLD, even though it's not specified in their graphic. If they are in the medium high symptoms burden but low risk, do all long acting. And where it really differentiate the two, it's about the step up for the most severe with the high risk. And GOLD has still not been convinced in the what I would call the successful approach as opposed to the failure approach. And what Paul has mentioned earlier on, then you have to fail in the failure approach, then obviously you step up. And what it may mean for patients that have severe disease and or severe exacerbation. Failing may mean another hospitalization, at best, at worst, dying from another exacerbation. Then I think it's not about us deciding the risk that our patient should be taken, because what we do by our decision and going with, because remember, what GOAL is doing is using the blood eosinophil 300 at a first evaluation. Okay, and then that second evaluation, if the patient still have exacerbation, then now the blood eosinophil count is not 300, it's 100 or more. Then we have decided that the patient will take that risk in between. Okay, where the successful approach is that on average, and that's what CTS recommend, on average, we think that the patient, the majority of patients are going to benefit from it. And we are willing to treat certain patients who might not need it, but for the benefit that most of the patient will need it, and the gravity, the severity of the problem is such that we don't want to miss the patient who are going to need it. Okay. And we are not stepping down also. Stepping down doesn't mean that you shouldn't reassess the treatment of your patient. Because if you think that your patient, okay, is not on the right treatment for reason ABC, that you can reassess the treatment. But as a general rule, if someone is successful with a treatment, I don't know any other chronic disease where you're just going now to stop the treatment that make this patient so successful that now stop to have exacerbation. And that's one of the reasons what GOAL have changed the ABCD or ABE for treatable threat, as opposed to going to, because if someone is D or E and become B, then you don't stop the treatment because he's responding to the treatment. Okay, then that's essentially, then I think the approach of the CTS guideline, it's about a successful approach in the very high risk group of patients, like we would do with any patient that have a myocardial infarction and ischemic heart disease.
One of the things I think that's come to us as we developed this guideline was that it was a misinterpretation. And I think people have seen this as a step-up approach. And I'm not sure how that got perpetuated over time. But at the end of the day, as Brandie highlighted quite nicely and Paul alluded to, it's an assessment and it's intervention. And that's what we're trying to promote, is that that people, you take a look at where that patient presents to you in front of you and what are the interventions, non-pharmacological and pharmacological, that they need to have. We're almost at time here. There's a couple other questions, but I just want to highlight what we're doing at the CTS. Since the guideline was published, we've tried to engage with the provincial formularies across the country, and including the NHIB. And at the end of the day, we've had some successes and some movements, as you've heard, as Paul alluded to, some changes in Atlantic Canada, the province of Nova Scotia. But at this time, CADTH, now known as the Canadian Drug Agency, is doing a class review of the COPD medications, as they've recognized that reimbursement across the country is quite variable and not stable across the country. So for us in this country, sort of in this universal healthcare system, it boggles our mind that why one patient in BC has a different access than the same patient in Atlantic Canada and across the way. So just know that we are on this and we are trying to help create change in events like today. We're hopeful that it'll lead to change. So I see Matthew has come on, and I think we're almost at time. So I want to thank everybody for your questions and your engagement, and I'll pass it back to Matthew.
Thank you. Again, there were a few questions, and I know that they tried to address them as best they could. I will forward the questions off to the speakers, and there may be opportunities for them to address them in other forums or other media, but it also helps them to understand what some of the questions and concerns are from you. With that, thank you, everybody. Wonderful presentation. Thank you to the speakers. Thank you for the attendees. Have a wonderful day. Take care. Bye-bye.
Thanks, everyone.
Thanks, everyone. All right. Bye-bye.